So this is basically kind of my journey from a posterior world to a more anterior world and now to my current status. At first I was kind of trying to figure out exactly what the point of this talk was and how it would benefit you, but I think part of it is that with my relatively recent transition being, in the last 5 years or so to the anterior approach, I may be a little bit more accessible than some of our other faculty that have been doing this for decades. And so I hope that this can help you kind of guide your journey and maybe not make some of the mistakes that I made. Basically my timeline, I started out posterior lateral in residency and then went to anterior lateral. I started out practice an anterior lateral surgeon. Then my first switched over to the direct anterior. I was on a traction table, and then after that I was off table and in my current practice model. Horberg was joking with me that it's time for another major practice change, so maybe I'll do them standing or something next, I don't know. But in residency, if you go from, Chimento was my mentor there, if you go anterior lateral, no one will dislocate, but they'll all limp, so we went posterior, and I was happy, and I thought I knew everything in the world. Then I got to fellowship. Mark Veris, my mentor there, he's like, no, if you go posterior, you're gonna have dislocations. We do fracture work, so we're a higher risk for dislocating. So you gotta go anterior lateral on everybody. So I was like, okay, now I know the world. I just came from Boston. I got it all figured out. And then I got to fellowship, or out of fellowship, started my practice with Dr. Moscow and everybody else down in Roanoke. I used fluoroscopy for my cup position like they taught me. I was happy. I didn't have any dislocations, but yeah, all my patients limped for a while. They all came in on a walker at 2 weeks. But overall, I was pretty satisfied. That was up until we have our joint council meeting every month. We sit down, we look at our length of stays, we hold each other to high standards, and I'm sitting there looking, okay, Moscow's getting most of his people out in a day. Wolf, same thing. Me, mine are all staying 4 days. This is not a great way. So I decided I needed to change something. So I was sad, and I decided when in Rome, maybe I'll change around. The way that I made my transition, granted I'm in a unique position in that I was already at a facility that had a lot of physicians that already were familiar and experts in the direct anterior approach. So I operated with partners, watching them do their cases, helping them with their cases for about 6 to 10 cases. And then my first cases were on my own, was the tail end of one of our fellows' years. And so the fellow helped me through. And then our new fellow came in. He helped guide me through. He already had experience in the direct anterior approach, and he wanted to master it. And so I felt like I had this really nice long proctoring period. So I was happy and making good progress. I think my learning curve was shortened somewhat. Partly because I always had somebody with me who already knew what they were doing and they could help get me out of trouble, and I always knew I had somebody across the hall that I could ask for help. And then also just my experience coming from a trauma-trained background. I'm not an arthroplasty-trained surgeon. I did a lot in fellowship, but I was trauma experienced, so I'm used to this approach, or at least approaches to the anterior portion of the hip for my trauma training. But that's not to say I didn't have my complications. So I had, broaches out of the femur, I had cracks, I had all kinds of the normal stuff that you would end up with. Things that I learned, so I stuck with the same stem. I listened to people, courses like this that said, when you transition to direct anterior approach, don't change your stem and your approach at the same time. Use something you're familiar with as you're migrating. I was using something with a full offset, kind of one of the anterior less friendly stems, if you will. And I used that stem for about 2 years before I converted to a more anterior friendly stem. I think that could have been a lot less maybe after my first 40, 50 cases or so. I didn't like the fact that I couldn't dynamically test. Coming from an anterior lateral position or posterior lateral position, I could always dynamically check. I could check my leg lengths. I had some sense of where things were. On the traction table, I didn't like taking the foot out of the boot. I didn't feel like I got a really good feel for things, so I didn't like that. And it took me a year or so before I was comfortable teaching the releases. It's a process. As you get more and you get more under your skin, you'll learn the release and you'll get more comfortable with the release. And then once you get comfortable with it, then you got to figure out, okay, well, now how do I tell other people how to do this to try to get it there? And so I think it took me a while. So at that point, when I was doing direct anterior for all my primaries, doing direct anterior for most of my revisions, and I was expanding my indications and comfort, at this point in time, it's rare that I go posterior for anything. And that was at that point before I decided that I was going to make a drastic change and go off the table. My problem with it was I'm a trauma surgeon again. I run a busy trauma practice, and on our trauma room days, I didn't have time to set up the Hannah bed to do a direct anterior approach for my hemiarthroplasty patients, and I was still doing anterior lateral for my hemis, and they were all coming in limping. Some were coming in on stretchers at 2 weeks, et cetera. So I got the privilege to go over and visit with Dr. Korten in Genk and his partner, and learned what they do. When I got over there, it was amazing how quick their efficiency is. There's a lot that you can learn from visiting other places and other countries and other sites. Things that we take as dogma in the US are drastically different. Dr. Korten's turnover time is 6 minutes from one patient out of the room to the next patient in the room, which I would challenge anybody here to have a time like that. And they come in with their spinal in place. So things that you didn't think were possible are possible. His normal day is 15 hips. So I came back. I didn't have his fancy tools and his retractors and stuff, so I found ropes and other positioning devices. I had my x-ray tech sample stuff and try to figure out exactly how I was going to do it, and I said, okay, here we go. We're going to go for it. My next patient, I'm going to do a direct anterior hemiarthroplasty. And this guy came in. He's a bilateral below-knee amputee. I'm like, well, I can't use a hand-to-bed, so that seems to make sense. So this was my first off-table direct anterior hemiarthroplasty. But despite my rope tricks and everything, it worked out. You'll notice I am doing longitudinal in this. I didn't want to change too much all at once. So we were able to successfully get him there and get him there. Things that I learned from that first case. Don't start with hemiarthroplasty. I'd been warned about it. I'm actually excited to hear Lee's talk a little bit later today regarding hemiarthroplasty in 2021. I think going to direct anterior for hemiarthroplasty is one of the biggest changes, other than not operating on proximal humerus fractures, that I've made in my practice since I've been out. It is life-changing. These patients come in 10 days post-op walking with no assist devices, even though they're like 85. It's really crazy. Don't make your trial long. Always err on the downsize. You can always upsize later if you need to, so I always go short. Thick mattresses don't work. Ropes aren't fun. The thick mattresses kind of get up in the way of your incision. There are design things that you can purchase that work, static retractors, lots of them are out there. And the bikini incision gets seromas. I got seromas for the vast majority of my bikinis at the beginning. It's because of the differential dissection between a transverse incision and a longitudinal deep dissection. If you suture your fat down to the fascia, it solves that problem. Femoral exposure on the table, the femoral elevation, you get your exposure by elevation extension. However, off the table, you get your exposure by adduction. You'll note that on the traction tables, most of them you are limited in how much adduction you can get based on the spars and them running into each other, whereas in a table-less situation, you can adduct as much as you want, 45, 60 degrees or so. So this is an example of femoral exposure on table on the left and off the table on the right. Again, you can see that adduction of 60 degrees or more. Physician ergonomics, I think off the table, you're working in a much more neutral position. On table, you've got that leg extended so much, so you're broaching in an up and down position, which is awkward. Off table, you're working kind of down in your best work zone. And so I think from an ergonomic standpoint, it's a whole lot more comfortable. Subjectively, I've done about 10 patients that I did on table and then off table. All but one like the off table version better. They report less paresthesias, earlier mobilization, et cetera. It's all subjective. I think my patients mobilize better. The hemiarthroplasty patients are mobilizing much better. And I think I have less wound problems with the bikini incision. Stay tuned. We're doing a randomized prospective on table, off table, single surgeon. I'll hopefully have more data. Maybe I can have a fellow. Also, from the efficiency of the off table, we found that we saved 13 minutes in setup, 30 minutes in surgical time, and for a 45-minute reduction in total OR time per case. That continued through my first 80 cases and continues to improve to this day. So I really do think that the transition may be frustrating. There's a number of things. Don't change all of them at once. Change them one at a time. Find mentors. And after a successful transition, I really do feel like I'm providing a better patient for my patients and better experience overall.